brief case presentation on central retinal artery occlusion. Let's see. Okay. The patient is a 42-year-old male with past medical history of hypertension, gout, smoking, type 2 diabetes, who presents with right eye vision loss. A month prior to presenting, he noted blurred vision to his right eye, and on February 10th, he woke up with a curtain coming up from the inferior vision of his right eye. On February 11th, he woke up with no vision in his right eye and presented to Duke Ophthalmology, where on exam, he was noted to have periorbital edema, chemosis, reduced extraocular movements, and fundoscopy showed retinal ischemia with peripapillary hemorrhages, minimal optic nerve edema, and white irregular lesions infranasal to the nerve. He was sent to the ED for further workup. Upon presentation, his physical exam findings were pertinent for right eye chemosis, upper and lower eyelid swelling and whitish discharge, a right RAPD, and right extraocular movements restricted in all directions, but most prominently with abduction. This is a picture of his fundoscopic exam where you can see the white irregular lesion as well as the peripapillary hemorrhages. As a part of his workup, an MRI orbits with and without contrast was done that showed enhancement to the right optic nerve as well as to the right periorbital fat. And you can also see the arrow to the left side that shows enhancement to the left periorbital fat, indicating that whatever process was going on to the right eye was also starting to affect the left eye as well. Additional workup included a lumbar puncture that overall was negative for infection and malignancy, serological workup that evaluated for inflammation and infection that was negative. We also did a biopsy of the right lacrimal gland and lacrimal fat, and his right lacrimal gland did show mild chronic dacryoadenitis, which is inflammation of the lacrimal gland, and lacrimal fat with no pathologic abnormalities. This is a picture of dacryoadenitis that I found on the internet, and you can see the right upper and right lower lid is extremely swollen for this child here. The patient was initially started on broad spectrum antibiotics to empirically treat an infectious etiology of central retinal artery occlusion. As workup continued, considering the overall clinical course, MRI findings, and intraop appearance not grossly suggestive of infection, and patho results that revealed the mild chronic dacryoadenitis to the lacrimal gland, an inflammatory etiology became highest on the differential, and IV methylprednisolone was initiated for the patient. Antibiotics were stopped. After the initiation of IV methylprednisolone, the patient's symptoms did improve with return of his extraocular movements, as well as reduced swelling to his right eye. Chronic dacryoadenitis is associated with Sjogren's, sarcoid, Crohn's disease, and IgG4-related dacryoadenitis. Ultimately, during the hospitalization, the exact cause of CRAO was not determined. However, an inflammatory versus neoplastic process was suspected. As IgG4-related dacryoadenitis was a working diagnosis for this patient, I want to briefly review IgG4-related disease. IgG4-related disease is a multi-system inflammatory disorder, and early recognition is important to avoid permanent organ dysfunction. Organs commonly affected by IgG4-related disease are the pancreas, bile ducts, retroperitoneum, salivary glands, and lacrimal glands. It usually follows a relapsing remitting course. Neurological manifestations of IgG4 disease are uncommon. However, it may be a life-threatening manifestation of treatable disease. The 2011 diagnostic criteria include characteristic diffuse, localized swelling or masses in single or multiple organs, elevated serum IgG4 concentrations, and histopathology demonstrating infiltration of lymphocytes and plasmacytes with demonstration of IgG4 plasma cells and fibrosis. When confirming involvement of the nervous system, workup may include CSF analysis, and histological analysis is required for hypertrophic pachymeningitis. The treatment includes glucocorticoids and sometimes an immunosuppressive agent, particularly rituximab. At the time, IgG4 dacryoadenitis was a working diagnosis for this patient, and ultimately he discharged with further outpatient workup. And these are my sources, and thank you for listening.
Thank you, Courtney. That was excellent. One other announcement, Andrew asked me to tell everyone that the sleep CME course is actually today from 4 to 6. Anybody interested in attending can email Victoria or Andrew for more details. And now to introduce our grand round speaker, I'm going to turn it over to Chris.
Thanks, Rich. Today I get to introduce Nate Ameri for his grand rounds. Nate, as many of you may already know, came from University of Virginia, where he did both his undergrad and medical school. Since he's been here at Duke, aside from developing a pretty good collection of bow ties, he's also been very involved in teaching and recruiting. So he's won the Appleseed Award from the medical students at least once. And this year was very involved in our virtual recruiting for our new residency class. He pretty much helped us figure out how we were going to do the Zoom interviews, how to set up everything the night before and during the day. So anything that went well this year, I think he gets a little bit of credit for that with our interview process. Now, if recruiting ends up being very poor next year, we'll blame him too, but I don't think that'll be the case. So Nate's going to be going on next year to Rush to do a movement disorder fellowship. Hopefully he'll get to hang out with Deeple a little bit while he's there. And I'm sure he's going to do very well up there. So Nate, I'll turn it over to you.
Thank you, Dr. Exxon, for the kind words. Let me make sure I can figure this out. All right. Does everyone see mountains?
You.
It worked. Okay. Here we go. All right, guys. Good morning, everyone. My name is Nate Ameri, and thanks for coming to my grand rounds this morning. I'm going to be talking to you a little bit about the history of Parkinson's disease. This is the disease that really got me into neurology and ultimately kind of decided my path to want to go into movement disorders. So it's something that's near and dear to my heart, and I had a lot of fun learning about the history. So I hope you guys enjoyed as much as I did. Disclosures, I have none. Financial disclosures, unfortunately, none yet. So before I begin, I'd like to highlight that as I researched the history of Parkinson's disease, I found that there is no way I could include everything in a single talk. With that said, I hope to highlight some interesting characters, developments, and stories, but acknowledge that a lot had to be left out. I'll specifically be concentrating on the earlier aspects of disease characterization, discoveries and pathogenesis, and a limited view of treatment development. So a quick kind of overview of what we're going to be talking about. I'll be talking about ancient descriptions and early treatments in the East, early Western descriptions, followed by early modern descriptions and approaches in the 19th and 20th centuries, the anatomical seat of Parkinson's disease and kind of the discovery of the substantia nigra, the history of levodopa, and I'll end with a curious story that led to a gold standard research model. My objectives, well, first and foremost, I want to kind of highlight that looking to the past and other cultures could always provide useful insight to us, and I hope you see that early on in the talk. And I really want to use history to review the cardinal features of Parkinson's disease as well. So let's get into it. Our story begins in ancient India. Early descriptions of symptoms and a syndrome similar to Parkinson's disease have been recorded in ancient Indian Ayurvedic medical texts since as early as 600 BC. In 600 BC, Sushruta, an Ayurvedic physician and surgeon, was the main author of the Compendium of Sushruta, or the Sushruta Samhita. It was considered by many to be a foundational text of Ayurveda, which is traditional Indian medicine, and included descriptions of over 1,000 illnesses, as well as medical preparations and surgical techniques. Among these were some of the first descriptions of slowness and akinesia, though they were not necessarily described as part of a specific syndrome that I could clearly elucidate from my resources. But this is kind of the first mention of them. Our next character got a little closer to characterizing an actual entity similar to Parkinson's disease. And this is Chakra, another Ayurvedic physician who is often referred to as the father of Indian medicine. He was particularly interested in tremors, and in his work, the Chakra Samhita, he described a syndrome characterized by rigidity, tremor, slowness, gait disturbances, dementia, and depression. This syndrome sounds an awful lot like our present-day Parkinson's disease, and incredibly, he not only identified motor symptoms, but non-motor symptoms, which were missed originally by Dr. James Parkinson himself. And important to keep in mind, he is ahead of him by almost 2,000, a little bit over 2,000 years. So equivalents of Parkinson's symptoms are abundant in Vedic scripts and appear in many different Vedic texts, some of which we've talked about. These symptoms are grouped under the term Kampavada, which seems fairly equivalent to our Parkinson's disease. I won't go through all these symptoms, but you can see here many of the motor and non-motor symptoms that comprise Parkinson's disease. These descriptions existed long before the descriptions of Dr. James Parkinson. I find it interesting that in another medical culture, so much discovery and description had occurred before popping up on the West's radar. What's more, there were even early treatments too. So treatment of Kampavada in Ayurveda involved a mixture of powdered seeds mixed in cow's milk. So the first plant to highlight is Mucuna perens. It's a type of bean also known as the cowwitch plant. Now what's amazing is much later, we discovered that it actually contains 4 to 6% levodopa, which probably explains why it was a good treatment. Then we have Hyoscyamus reticulatus. Hyoscyamine is an anticholinergic, which helped treat tremor. We have Withania somnifera, or as many people now know it as a popularized supplement, ashwagandha. The reason this is felt to help is a little unclear, but from what I could read, it's hypothesized to have a neuroprotective effect. And then finally, Sita cordifolia, which contains ephedrine. And again, I'm a little unsure why this one would work other than maybe Parkinson's disease is a disease of slowness, and the thought is giving a stimulant might help. And finally, I'd like to make a brief note in China and one of the descriptions that was made in Chinese text. I will say that there is a larger story to be said in China, but when I was going through my resources, I found that China was mentioned a little more often and almost no one mentioned India. So that's why I decided to concentrate on India in my talk, but I think this description is worth mentioning. So in the 13th century AD, Dr. Zi Zhang in 1228 described a syndrome characterized by tremor, stiffness, unexpressive facial features, loss of dexterity of the fingers, depression, and that this disease had a chronic progressive course with a very poor response to drugs. Again, seems quite familiar to our now known Parkinson's disease and discussed over 600 years before Dr. James Parkinson made his descriptions. So now I'm going to turn our attention to the West. We will start in ancient Rome with Galen of Pergamon. So Galen of Pergamon was a famous anatomist, an experimental physiologist in ancient Rome. Among his many interests and accomplishments, he did a lot of work studying the spinal cord, nerve roots, and had a keen interest in the neurological maladies, specifically tremor. He was the first to clearly distinguish between resting and intentional tremor in his work De Tremori, Palpitazione, Convulsione et Rigore in 169 AD. In his work, he made the earliest statement regarding a shaking palsy. The next notable mention will not come in for another 1300 years by a character that we all know pretty well, but maybe not for this reason. And that is Leonardo da Vinci. Leonardo da Vinci presented a quite detailed description of the shaking palsy as a combination of difficulty with voluntary movement and tremor. A translated note from da Vinci in his anatomical manuscripts in the Windsor Castle collection reads, "This appears clearly in paralytics, who move without permission of the soul, which soul, with all of its power, cannot prevent these limbs from trembling." Again, in this description, we hear both trouble moving and an inability to stop moving, which, as we all know, is pretty characteristic of this disease. The story continues to build in Hungary in about another 300 years with Dr. Ferenc Papai Paris, who was a Hungarian physician. In a textbook he wrote in 1960, he describes 4 cardinal symptoms of Parkinson's disease 120 years before Dr. Parkinson. So I included some excerpts, and I don't expect that you guys can read them, but I thought they were pretty interesting to look at, and I'll tell you what they mean. So here, in A, he talks about tremor of the head or hand or both. Here, he talks about rigidity. In C, hypokinesia without sensory loss. In D, instability of gait. Now this excerpt here, in E, he described a progressive course and onset in older age. And in F, suggested signs are due to a disease of the brain. It is unclear why he was not better known for these writings, But our next character may be one of the most famed in the story of Parkinson's disease. That is none other than Dr. James Parkinson himself. Dr. James Parkinson was a British physician for whom our disease is eventually named. After studying Latin, Greek, and natural philosophy, James Parkinson started his medical studies. He is best remembered for his descriptions of a syndrome he referred to as both the shaking palsy or paralysis agitans. He wrote his famed essay on the shaking palsy in 1817. In his essay, he characterizes both motor and non-motor symptoms of the disease and describes 6 cases. His descriptions have endured to this day in our clinical diagnosis of the disease. He describes 6 cases in total, 5 of which were mostly observed casually in the streets of London. After describing his 6 cases, he notes, "The preceding cases appear to belong to the same species, differing from each other, perhaps only in the length of time which the disease had existed and the stage at which it had arrived." He also notes the older age of onset and insidious onset. On page 1 of his essay, Dr. Parkinson describes the shaking palsy. And he says, as you can see up here, "Involuntary tremulous motion with lessened muscular power, in parts, not in action, and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured." So here he touches on quite a few characteristics of the disease, including resting tremor, segmental onset, stooped position, festination, though I will say he notably thinks the intellect is not affected, and this could honestly be because people at the time didn't live long enough to develop the later stage manifestations of the disease. He saw patients as suffering from weakness, which we now know to be incorrect. He missed bradykinesia, which will be later discussed in more detail by Dr. Charcot. So he does mention a lot of the motor features of Parkinson's disease, and I'd like to kind of run through them and how he described them, little excerpts through the essay. So regarding resting tremor, he notes, "Occurring whilst the affected part is supported and unemployed, and being even checked by the adoption of voluntary motion. Regarding shuffling gait, the legs are not raised to that height which the will directs." And even in his 6th case, the one that was the most well described as he had ongoing correspondence with the patient, he notes at the later stage of the disease, the patient says he couldn't even step over a nail lying on the ground. Shortened stride and festination, Dr. Parkinson notes, the patient being irresistibly impelled to take much quicker and shorter steps, adopts unwillingly a running pace. Regarding flexed posture, Parkinson not only pointed out that the characteristic flexed posture peculiar to patients with PD, but also the severe degree of this trunk flexion that we now call camptocormia. He notes the propensity to lean forward becomes invincible. The upper part of the body is thrown so far forward as to render it difficult to avoid falling on the face. And finally, hypophonia. He noted this in his clinical descriptions and noted that the patients who were either in the later stage or with patient 6 at the end became very, very difficult to understand. And finally, on some of the non-motor symptoms, this was a little difficult for him to characterize because 5 out of the 6 cases he observed from afar, which obviously you can mostly see motor symptoms from afar. But he did notice sleep disturbances, noting patients would have disturbed sleep, often owed to tremulousness and disturbed movement. I do wonder if some of this was REM sleep behavior disorder or purely tremor that was untreated. He notes pretty bad constipation that got very bad towards the end of the disease, and also hypersalivation. Now, a lot of you may know that salivation is also mostly actually a motor problem, and Dr. Parkinson correctly identified this, noting that it was more of a trouble of swallowing. So, Dr. Parkinson did take a stab at underlying pathology. Parkinson noted that there had been no prior anatomical examinations of patients with his described disease, and that his hypothesis could only be based in opinion, unfortunately not facts. He hypothesized that the disease originated in the superior spinal cord and progressed to the medulla. He, however, incorrectly hypothesized that this encephalon was not involved as the senses and intellect were thought to be unaffected. He did not know the cause, but had assumed it was an inflammatory disorder. He postulated that chronic inflammation following infection may play a role, likely fueled by post-encephalitic Parkinsonism seen in the flu epidemic. Oh, whoops, excuse me. Erase that thought. Dr. Parkinson did talk a little bit about treatments. Bloodletting was a big treatment of the time, and he doesn't describe a whole lot of whether or not it worked. One of his patients did get bloodletting done, but ended up moving out of town, and he was unable to talk about whether or not it helped or did not. Blistering was another thing that was done commonly and was often done by inserting pieces of cork underneath the skin. He hypothesized that this would pull blood and inflammation away from the brainstem, which he thought was involved in the pathophysiology of the disease. And then finally, he talked about the use of aperients or laxatives. And as I told you, he did note that severe constipation was a part of this disease. And while there were not many good treatments or any good treatments for the disease in the West at the time, he figured you could treat some of the symptoms. We will next turn our attention to France to learn from Dr. Charcot at La Salpêtrière Hospital, who over 50 years later shed new light on the disease and explored new therapeutics. Jean-Martin Charcot was a famed French neurologist who worked and taught at the famous Petit Salpêtrière Hospital for 33 years. In his teachings, he was more thorough in his descriptions of what is now known as Parkinson's disease, and notably distinguished bradykinesia as a separate cardinal feature of the illness and rejected the weakness as a cardinal feature. Dr. Charcot rejected prior designation of the disease as shaking palsy or paralysis agitans, and I'll read this little quote from him. Long before rigidity actually develops, patients have significant difficulty performing ordinary activities. This problem relates to another cause. In some of the various patients I showed you, you can easily recognize how difficult it is for them to do things even though rigidity or tremor is not the limiting feature. Instead, even a cursory exam demonstrates that their problem relates more to slowness in execution of movement rather than to real weakness. In spite of tremor, a patient is still able to do most things, but he performs them with remarkable slowness. Between the thought and the action, there's a considerable time lapse. One would think neural activity can only be effected after remarkable effort. He noted that patients were not markedly weak and did not necessarily have tremor. He tested them with dynamometers and found their strength to be normal for most of the duration of the disease. For these reasons, he dismissed the terms paralysis agitans and shaking palsy and coined the term Parkinson's disease in honor of Dr. Parkinson. Additionally, he and his students noted two prototypes of the disease that we still use today, tremors and akinetic rigid. In one of his famous Tuesday lessons in 1888, he presented a case in which he demonstrates a formerly unidentified aspect of the disease, retropulsion. He lectures, "You notice the tendency to run ahead, propulsion, so aptly noted in Parkinson's original description. I'm going to show you how, in addition to propulsion, there's an equally marked tendency for the patient to retropulse. To demonstrate this, I will stand behind the patient and pull on his clothes 2 or 3 times to displace him backwards. This maneuver must be carefully performed, for once the retropulsion begins, the patient continues to fall backwards, and if not stopped, may well fall." In this lesson, he describes his pull test, and this is a test that anyone who's examined a Parkinson's patient will know we still use today to characterize retropulsion. I'll now move on to some of the great contributions Dr. Charcot made to the disease at the time, therapeutics. Up until now, Western treatments of the disease were quite limited, as you saw with Dr. Parkinson's described treatments. So things Dr. Charcot used, one were anticholinergics. So belladonna alkaloids were one, an anticholinergic agent used to treat Parkinson's disease tremor. That was the first well-established treatment of PD in the West. Centrally active anticholinergic drugs would later be understood to affect the cholinergic dopaminergic balance in the basal ganglia, specifically striatum, and thereby improve Parkinsonism, specifically the resting tremor. As we now know, PD is caused by degeneration of the neurons in the nigrostriatal pathway, leading to depleted dopamine levels in the basal ganglia. This leads to a relative excess of acetylcholine that can be corrected for with anticholinergic agents. Hyoscyamine was another agent in his arsenal. He was not the first to use this, but popularized its use. As we discussed earlier, this had been used many years prior by Ayurvedic practitioners in India. Hyoscyamine was one of the choice anticholinergic agents used by Dr. Parkinson, and also one of the choice anticholinergic agents of the era. Dr. Charcot prepared it as a powder rolled into bread pills, or sometimes gave it as a syrup. He also combined rye-based ergot products, as seen in the prescription shown here. This eventually was the pharmacologic basis of some of the modern dopamine agonists that directly stimulate striatal dopamine receptors. Charcot was well known for continuing correspondence with his patients through letters to track the effects of his treatments. Finally, Dr. Charcot pioneered an interesting physical therapy device designed following an interesting observation. Charcot noted, "I had long been told by patients with paralysis agitans that they derived great relief from prolonged journeys by railroad or carriage. During these travels, the uncomfortable and often painful sensations implicit to this disorder seemed to almost completely disappear, and the benefit persisted for some time after the journey." Charcot published studies on his device. He tested it in a series of patients at different durations, but found that 30-minute sessions seemed to be the most feasible to avoid the development of fatigue. Per his observations, patients demonstrated improvement after the 5th or 6th treatment. There was no effect on tremor, though he documented patients felt a greater sense of lightness, less stiffness, and walking improvements, as well as improved sleep. In his words, "An almost constant phenomenon, the nights become good. The patient who before was agitated incessantly in bed sleeps peacefully, which brings him great satisfaction. It is no small gain to be able to relieve the sufferers of paralysis agitans, a disease for which ordinary remedies have, as you know, so little efficacy." We see his chair pictured here, and actually here's a device by one of his students, Gaz de Tourette, which works on the head. An article in October of 1982 in Scientific American reported on Charcot's findings in relation to PD and his vibration chair. These motions produce a series of very strong trepidations. It is the motion of the sieve for the sifting of industrial materials. There could be nothing more insupportable for a well person than such shakes which demolish you, put you out of order, and shake up your intestines. And after a half-minute's experience, you would ask for mercy. The invalid, on the contrary, lolls in the chair as you would on a soft sofa. The more he is shaken, the better he feels. After a sitting, he is another man. His limbs are relaxed, the fatigue has disappeared, and the following night, his sleep is perfect. So interestingly, some of these findings have been confirmed in modern studies. A study in 2008 showed improvement in get up and go, as well as UPDRS scores related to gait, up to 4 weeks after treatment with whole body vibration therapy. Finally, I'll turn my attention to Dr. William Gowers. In addition to what had been noted by prior physicians, Gowers correctly identified the slight male predominance of the disease. He was also involved in promoting different therapies for tremor, including hyoscyamine, which you've heard about before as an anticholinergic, hemlock, which is a quite poisonous flower with anticholinergic properties. He was particularly interested in cannabis, actually, writing specifically of the power of cannabis and opium in combination. He stated, "I've several times seen a very distinct improvement for a considerable time under their use." Today, cannabis is known to have some dopaminergic activation properties, which may be why he saw benefit. He advocated for opiates, which affect the motor system in a more generalized sedative manner without direct or primary dopaminergic involvement. With the disease well clinically characterized and described, the interest of the time now shifted to its etiology. Our story starts with the discovery of the substantia nigra and a pair of physicians who co-opted at La Salpêtrière in France. Dr. Bernard Loys, not pictured here, was a French psychiatrist working at La Salpêtrière. In 1865, he published a book containing the first identification of the substantia nigra. Next in her story is Dr. Georges Marinescu, who we see pictured on the left. He was a Romanian neurologist who collaborated with Dr. Paul Oscar Bloch, a pathologist at the Salpêtrière in France. In 1893, a 38-year-old man suffering from tuberculosis was admitted to Charcot's ward and was under the care of Jean-Baptiste Charcot, who was Charcot's son. The patient developed unilateral left-sided resting tremor and Parkinsonism. At autopsy, doctors Marinesco and Bloch noted an enucleated tuberculoma the size of a hazelnut in the substantia nigra on the right, so contralateral to the Parkinsonian symptoms. Notably, the corticospinal tract, superior cerebellar peduncle, and cerebral peduncle were all largely unaffected. This finding caught the interest of Dr. Edard Bresson, who's pictured with Marinesco on the right. Dr. Edard Bresson, based on the observations of Dr. Marinesco, postulated that the substantia nigra was involved in control of muscle tone and that a lesion to this area caused Parkinson's disease. And in 1899, he officially stated PD was caused by, or he officially stated that he thought that Parkinson's disease was caused by damage to the substantia nigra. Unfortunately, most people paid little attention to this and concentrated on the striatum and its output pathways. It would take about another 20 years for this theory to gain more traction with the work of a Russian physician, Dr. Konstantin Tretiakov. Dr. Konstantin Tretiakov was a Russian immigrant who worked as the head of the laboratory of the nervous disease clinic at the Salpêtrière. He was interested in and studied encephalitis lethargica patients, many of whom developed post-encephalitic Parkinsonism. And as you may know, there was a large burst of patients of this type around 1920 with the flu epidemic. In 1919, he performed a detailed neuropathological study of the substantia nigra in 54 brains, 9 of whom had Parkinson's disease, 3 of whom had post-encephalitic Parkinsonism. Compared to age-matched individuals without signs of Parkinson's disease, seen in figure 5A, or figure A, he noted that in all the Parkinson's disease cases he examined, that there was marked loss of pigmented nigral neurons with swelling of cell bodies, degeneration, and neurofibrillary alterations, seen here. Surviving nigral neurons were found to harbor typical neuronal deposits that he named Corps de Louis in recognition of the German neuropathologist Frederick Louis in 1912, who first noted these cytoplasmic inclusions in the dorsal vagus nerve of Parkinsonian patients. He concluded, hence the results of our research lead us to think there exist intimate relationships between the substantia nigra and Parkinson's disease. These relations are very likely that of cause and effect. His work raised considerable doubts among his colleagues, who rejected the idea that lesions of such a small structure could cause motor disorders as massive as those encountered in Parkinson's disease. Many at the time accepted that the substantia nigra was undoubtedly involved, but still believed that the most important lesions would be those that targeted the most important input and output structures of the basal ganglia, the striatum and the globus pallidus. It wasn't until 1938 that a young German doctoral student would provide histopathological evidence to set the record straight. That young German doctoral student was Dr. Rolf Hassler. In a paper in 1938, he elucidated in unprecedented detail the neuropathology of Parkinson's disease and post-encephalitic Parkinsonism. His post-mortem studies revealed that the striatum and the globus pallidus were largely unaltered in patients with Parkinson's disease and post-encephalitic Parkinsonism, whereas dense clusters of neurons in the ventral part of the substantia nigra pars compacta were severely affected, with surviving cells containing numerous Lewy bodies. The anatomic seat of Parkinson's disease was finally settled after almost 80 years. Now I'd like to shift our attention to dopamine. Prior to levodopa, centrally active cholinergic drugs were the mainstay of therapy. The emphasis of the former period remained on supportive physical therapy and the treatment of tremor, hypersalivation, and infections. As we know now, the use of dopamine revolutionized the care of patients with Parkinson's disease and is to this day a staple of therapy. Dopamine was first synthesized by George Barger and James Ure at the Wellcome Laboratories in London. At the time, dopamine was only seen as a simple intermediate compound for the synthesis of noradrenaline and adrenaline. It was not until the mid-1950s that it began to emerge as a substance of importance in its own right. In 1958, Arvid Carlson, pictured here, discovered the presence of dopamine in the brain. This observation was further localized by a Swedish research group who identified high concentrations of dopamine in the striatum of mammals, leading to the theory that it played a role in basal ganglia function. It would be another 2 years before the substantia nigra would be implicated as an important player in the story of dopamine by an Austrian biochemist, Ole Hornikowitz. 1960 was a big year for dopamine discovery and advancement. Dr. Hornikowitz, pictured here, discovered that dopamine levels were depleted in the striatum of patients with Parkinson's disease and post-encephalitic Parkinsonism compared to healthy controls. About the same time, Swedish investigators with the development of histofluorescence detected the presence of dopamine in the vast majority of the substantia nigra pars compacta neurons and traced their axonal projections to the striatum, which we now know is the nigrostriatal pathway. The same year, Dr. Hornikowitz started to synthesize levodopa, a compound that is converted to dopamine in the brain. A fellow physician took a keen interest in this compound and was eager to try it in his patients. That doctor was Dr. Walter Birkmeyer, an Austrian neurologist who received Dr. Hornikowitz's supply of laboratory levodopa in 1961 and injected it intravenously for the first time in Parkinson's patients. He noted, bedridden patients who were unable to sit up, patients who could not stand up when seated, and patients who, when standing, could not start walking, performed all these activities with ease after levodopa. They walked around with normal associated movements, and they could even run and jump. The voiceless, aphonic speech, blurred palalia, and unclear articulation became forceful and clear, as in a normal person. In 1968, Dr. George Katsayas, who's pictured here, published a paper in the New England Journal of Medicine describing his successful use of oral levodopa with gradual titration to minimize side effects, which was a big problem with the IV formulations used by Dr. Birkmeyer. In 1969, subsequent open-label levodopa trials with oral preparations confirmed both long and short-acting benefits. Short and long-term benefits. This was further confirmed in double-blind placebo-controlled trials published the same year. In the early 1970s, George Katsayas improved on levodopa and established the combined use of levodopa with a peripheral dopamine decarboxylase inhibitor, now known as carbidopa. This prevented levodopa from being broken down before it reaches the brain, allowing for lower doses to be used, leading to less nausea and vomiting. This is why the combination pill is now known as Sinemet, or Sin-Emesis. I would like to end my talk with a very interesting story that I came across that shows how scientific developments can be found in the strangest situations. This is a tragic story that led to what is now used as the gold standard in animal research models for Parkinson's disease. The discovery came out of this tragic story opened the door to many continued years of advancements in Parkinson's disease therapeutics. This is the story that became known as the case of the frozen addicts. It is both a book and a great documentary from the 1980s, loaded with some excellent 80s CGI, including laser beams backed by Star Wars-esque sound effects blasting the substantia nigra. If you have time, I would highly recommend watching. To set the stage, it was the summer of 1982 in July. Don't You Want Me by the Human League was at the top of the charts, and E.T. was the blockbuster of the month. Now that I've hopefully helped transport those of you who are alive at the time back to that setting, we can begin our story. On July 16th, 1982, George Carrillo, a 42-year-old man, woke up in a California prison after a night of using heroin to realize that he was completely unable to move. Dr. J. William Langston was the consulting neurologist called into the local ER to examine the patient with a chief complaint of generalized paralysis. At first, the patient seemed to be completely frozen and unable to talk. However, on closer examination, it was noted that extraocular muscles were intact. It was also noted that with enough patience, the patient was able to move, just very, very slowly. With coaxing, they discovered that he can even write, "I can't move." This proved that mental status was still intact to some degree, as was fine motor function. Shortly after, Mr. Carrillo's 30-year-old girlfriend had presented with similar symptoms. She exhibited freezing, bradykinesia, right upper extremity tremor, and inability to speak. Shortly after, 2 brothers also presented with the same symptoms. Dr. Langston quickly elucidated that all of the patients had used heroin the night before presentation, though he had never seen heroin have this effect. After the first 4 cases, Dr. Langston went to the news to send out a warning of potentially tainted heroin. 7 cases were reported in total, notably a woman named Connie, who turned out to be the most affected and who we'll see a little bit later, had been committed to a psych ward with, and I quote, hysterical paralysis. Though thankfully, an astute public health nurse called the case in to Dr. Langston, noting that it sounded eerily similar to the cases he warned about in his news report. Once the cases were identified, local authorities went to the houses of the victims to collect samples of the heroin for testing. When tested, absolutely no heroin was identified, and instead test results revealed an unknown substance. Through some good police work, authorities identified a list of suspects and noted one man with a record of designer drug production was noted to be buying large quantities of unusual equipment and chemical reagents. Unfortunately, at the time, there was no law against the production or distribution of chemicals not yet specifically legally classified. So they could do nothing when the man said he was working on hand lotion and, I quote, a formula for a better snow cone. This was odd since the reagents were very expensive and mostly flammable or explosive. Not ideal for hand lotions and snow cones. Dr. Langston, a neurologist, quickly noted that his patients clinically appeared to have Parkinson's disease. While it made no sense at the time that the normally insidious disease of older patients had afflicted his younger patients, he decided to try giving them levodopa. It turned out to be incredibly effective in alleviating the symptoms of all the patients affected. I'd like to show you one of those patients, Connie, which we talked about earlier, so that you can see her clinical symptoms and her incredible response to levodopa. Let's see. I apologize for the poor resolution. It is an old documentary.
It has the power to transform even an invalid like Connie, who without medication has no voluntary control over her movements.
I'll do that again a little later when hopefully the medicine works. Now what I want you to do is try to reach out and touch my finger.
So this is her before the
Let's try
levodopa.
to make it a little easier. Try to just take this hand and just reach up and touch my hand. Can you do that with your fist? Just get your arm up there. Do your best. Try to get your right arm up there. Are you trying? Okay, so you can't really do that right now. I can see the tremors getting a little worse. Let's try it on the other side. Just try to hit my hand like a boxer. Can you do that? Let's try to hit my hand.
L-Dopa gives her back what most people take for granted, voluntary control of her body.
You couldn't even do that a while ago, could you? And actually, that's quite fast. Good. Now let's try it with this hand, okay? Same thing. Tip of my finger to your nose. Very good.
But the miracle has a price.
Several of them.
So as y'all can see, a very, very severe presentation of Parkinsonian symptoms and an extreme response to levodopa. In reviewing the literature to try to find answers in similar cases, a colleague brought up a case report of a 23-year-old patient from 1976, 6 years prior. This was the case of Barry Kidston. He was a 23-year-old undergraduate student who presented with a syndrome that looked just like Parkinson's disease. It was discovered that he was attempting to synthesize a Demerol substitute, which would be legal. He was seen at the National Institute of Mental Health, who noted improvement with levodopa. When they tested his drug, it was a compound called MPPP. This compound was studied on only rats and noted to have similar effects, but only temporarily, leaving researchers without a clear explanation for Barry's presentation. Dr. Sanford Markey, who had taken interest in the case, figured MPPP was not the the full story and discovered that due to some sloppy chemistry, if too much heat is used, another product, MPTP, is formed, which would later be found in small amounts in Kidston's reaction chamber. At the time, this was never tested in rats or any other animals for no clear explainable reason. Unfortunately, in September 1978, Barry took his own life. His body was sent for autopsy, and to researchers' amazement, his substantia nigra was extensively damaged, like in a Parkinsonian patient. The rest of his brain remained untouched. Researchers had discovered a synthetic substance known to induce a permanent Parkinsonian state and specifically target the substantia nigra. This begs the question, why was this not more well known? And the answer lies in publication politics. So at first, the paper was submitted to the New England Journal of Medicine, who rejected the paper on technical grounds. JAMA deemed that there were too many authors and that one would arbitrarily have to drop out. Unfortunately, and of course, none of the authors were willing to drop out. The authors ended up publishing in the first volume of Psychiatry Research in Holland, which is hardly read, and unfortunately the case was lost to obscurity. Upon hearing about the cases in California, the National Institute of Mental Health began to reopen examination of MPTP, since Barry Kidston was no longer an isolated case, and there might be an epidemic on the rise. They finally tested pure MPTP, which was the chemical made if MPPP was synthesized with too much heat. They tested it in rats and were surprised to find no effect. Thankfully, someone hypothesized that perhaps rats were not a perfect analog to humans and tested it in monkeys. The monkeys developed a full Parkinsonian-like syndrome that was reversed by levodopa. This was published in 1984 and marked the development of a gold standard animal model for Parkinson's disease that is still the gold standard today. I would like to take this moment to remember 6 of the patients that led to this discovery: George Carrillo, Juanita Lopez, David Sylvie, Bill Sylvie, Connie Sains, and Toby Govea. Today, only 2, Connie and Toby, are still alive. Notably, Toby was one of the first patients in the United States to undergo DBS. So a couple conclusions. When looking back at descriptions in India and China, Parkinson's disease was described long before it was observed by Dr. Parkinson, and therapeutics existed long before they were explored by Dr. Charcot. There can be great insight gleaned from the past, and I think that's important to remember. Parkinson's disease is a complicated disease with widespread dysfunction related to dopamine depletion and degeneration of the substantia nigra. Which, again, it's interesting that for so long, the theory that the substantia nigra was this, I guess, one of the originations of this disease was rejected because people thought that such a small structure could not have such a big effect. And then finally, the gold standard animal research model was born out of a tragedy and great investigational neurology. The story of the frozen addicts is a great reminder that great discovery can be found in the most peculiar observations. I hope that you all have had a greater appreciation for the complex history of this disease. While my history is abbreviated and far from complete, I hope you enjoyed learning more about how far we've come over the last 2,600 years. Couple thank yous. Of course, I'd like to thank Jackie, my wife, pictured here. She helped me hatch the idea of this talk and listened to a lot of neurological history while I developed it. Colby, my kitty, sitting in the top right. Special thanks to Sarah Cantrell and Rachel Ingold. These are 2 of our medical librarians who have been completely instrumental in helping me find resources and forming this talk. I just shot them a quick email, and within a couple of days, I had a whole collection ready for me in PubMed. So as you all move forward, if you're doing any projects, I could not recommend working with them more. They have been fantastic. I'd like to thank Dr. Mitchell, Dr. Haas, Dr. E. Wayne Massey, who got very excited when I told him I was doing a historical piece and was kind enough to share a lot of his slides, his pictures, and a book that was very helpful for the formation of my project. And I'd like to thank my mom and dad, who I would not be here without. And I know you guys are in the crowd out there somewhere. So love you guys and thank you for everything. And finally, to all my wonderful co-residents who have made the last 4 years wonderful, fun, and helped me get through it. So thank you all. Here are my sources. Here are my picture credits. And yeah, I can take any questions if there are any.
Thank you very much, Nate. So if anyone has questions, just put your name in the text and we'll call on you. So Nate, you probably know, but the MPTP monkey was what was used by Malin DeLong to outline the physiology of the basal ganglia and the idea that the subthalamic nucleus was hyperactive, which then led to ablation of the subthalamic nucleus, which eventually led to DBS, which is what the patient got treated with.
Yeah, I shed actually a small tear when I couldn't talk about DBS or any of the surgical stuff, which was in my original talk, but I realized, as you can see, I already went very close to time. So I could do a whole nother talk and all of that, but yeah, thank you for sharing that fact that I didn't. Another interesting thing that I didn't mention is MPTP was actually tested earlier by a pharmaceutical company for the treatment of Parkinson's disease. And actually 2 of their subjects died, I believe, which the reason that this was allowed to happen is when they tested it in rats much sooner, nothing happened. So they said, oh, it's safe. And it kind of highlights, thankfully there's a change in research protocol that we can't just test something in a rat and then go straight to humans. Because as we, as I'm explaining now, that can lead to tragic outcomes.
All that's coming in is great talk, great talk, great talk, great talk with some hand clapping. Thanks, Nate. Great talk.
Thanks, everyone.
All right. Yeah. Take
Do
care,
I
Nate.
have, we have time to make a
Yes,
comment?
absolutely.
Wonderful, Nate. Really good. I can remember 1970 being an intern, in June of 1970 is when L-Dopa came on the market, and it made it, people took up their bed and walked. It was so wonderful. But we had to use huge doses of L-Dopa, as everybody knows, until 76. In June of 76 is when the combination of carbidopa and L-Dopa came out and let us use less amount. But during those years, first years, people got up and started moving. In fact, some of them hurt themselves and broke a bone because they fell, because they could do so much more than they did before. It was wonderful. Thank you so much for the tremendous insight.
Of course, sir. Thank you.
Marvin, are you out there? Don't know if Marvin's out, but he
Yeah, can you hear me?
Yeah, go ahead, Marvin.
I just wanted to this is just a little tiny comment. I think the picture you had of Parkinson was actually a picture of a dentist in London who had the same name. I don't think that image relates to the eponymous doctor for your disease, kind of thing.
Well, then I was tricked by Google search and Wikipedia, because I myself had never actually seen Dr. Parkinson himself.
Nate, you're not the only one. Kevin Van Landingham put a reference to a Lancet piece that kind of sorts out who is who in the chat section.
But
Thank you, Dr. Roger, for setting that straight. I'll have to fix that.
Okay.
All right, everyone. Any other questions? If not, have a great and safe day, everybody.
Thanks for listening, everyone.
Thanks.
Have a good day.
Sure.